Tēnā koutou katoa. Ngā mihi nui ki a koutou katoa karanga mai mihi mai. And hello from Tapu Taranga, Wellington. Greetings to everyone joining us today. Ko Kali Mercia Tokawengawa. I'm Deputy Director of the Helen Clark Foundation, and I'm delighted to be hosting a very esteemed and knowledgeable panel today on long COVID. We have great speakers. We have such an interesting and important topic to talk about. So I can't wait to get stuck in. Before I introduce the panelists to you, I'm going to start off the webinar in the right way with a karakia. Tuia ki runga, tuia ki raro, tuia ki roto, tuia ki waho. Tuia te here tangata, tuturu o whiti, whaka maua ki tina, tina, homie, huie, tai ki e. So I chose that karakia to start this particular webinar because it talks about the importance of unity and pulling together in the same direction, and often for long COVID patients, they often feel they've been left to work through this debilitating condition on their own without very much guidance. So this webinar is dedicated to all those long-suffering patients out there, and a special welcome to those of you joining us today. As always, also a very warm welcome to our Helen Clark Foundation members. The Foundation is a public policy think tank based at the Auckland University of Technology. We're non-profit, evidence-based, non-partisan. If you're not already a member and you like what you hear today, we do invite you to join our free online newsletter or sign up on our website to become a member. So we have a lot to cover today. We're going to be hearing up-to-the-minute research on what long COVID is, who it affects, and what we could be doing better in Aotearoa to support patients, and also, of course, to prevent new people coming down with the condition. So I'm going to get our amazing panelists to introduce themselves in just a second and get the webinar started. But first, some very quick housekeeping matters. Just to reassure you, your microphones are off. We can't hear you or see you, so you can go and get your lunch if you need to, or move around the room. If you have a question for the panelists, we invite you to put that into the Q&A section, which should be at the bottom of your screens on a PC. If you don't have a question yourself, you can still look at those questions and you can vote them up so that the questions with the most votes will be asked first. So please do that. You can also use the chat function to talk to other participants, but just to note, we won't necessarily be looking at that much during the webinar. So if you do have a question, use that Q&A function, please. Also, we're going to be recording this, so you'll be able to watch it from tomorrow, probably on our website or our YouTube channel. So if you are struggling with energy or with concentration, please do remember you can watch it again later. So how we'll run the talk today, I've got some structured questions for the panelists to begin with to make sure we cover all our bases. And then we're going to have a good 25 minutes at the end of the webinar for questions from you, the audience. And we'll be finishing up about 1:15 today. I'd also like to note quickly before we get started that there are people out there who don't believe in COVID or long COVID, or perhaps think that COVID is caused by a vaccine rather than by COVID itself, or that long COVID is. If that includes you, you're welcome to be here and to listen and learn, but I would ask you please not to make any comments on the chat or in the Q&A that undermines or negates the experience of long COVID patients. It's very real, it's a very debilitating condition, which I can testify to as I have it myself. So just to note that we will remove anyone from the webinar who's unpleasant, unkind, or abusive. So normal rules of niceness apply, please, guys. I would like this to be a safe space for patients and obviously also for our panelists who have joined us today. So thank you. I'm going to ask each of the panelists now to introduce themselves. Let's start off with you, Michael.
Well, kia ora koutou. It's wonderful to be on this multidisciplinary panel. I'm a Professor of Public Health at the University of Otago in Wellington. I've been following the COVID-19 pandemic from the earliest days in 2020, and I've become very concerned about long COVID. And I know it's not just an academic issue for many of you, it's a deeply personal issue that affects your lives and the lives of many thousands of people. So I'm very interested in being involved in this discussion today. So thanks for listening.
Kia ora, kia ora koutou. I'm Paula Lugali, Professor of Health Economics at the University of Auckland. And along with Janine, I've created the Long COVID Registry, which I'll speak to some of that evidence today. Janine.
Kia ora, I'm Janine. I am Long COVID Support Aotearoa founder and co-founder with Paula on the Long COVID Registry. I didn't come from academia. I come from being a patient, one of our very first ones in Aotearoa with COVID and then with long COVID. And I bring with me experience. I've been a tech founder for the last 25 years.
Hi, I'm Warren Tate. I'm a biomedical researcher from the University of Otago, Dunedin, now an emeritus professor. I come to this from the dual lens of researching ME/CFS and long COVID for the last 12 years, and also from the lens of a ME family of 35 years duration.
Well, thank you, everyone. We're very lucky to have such a knowledgeable group to share your wisdom today. So thanks for being here. I'm going to start with you, Michael. As a public health expert, it would be good if you could frame up the issue a bit for us to start off. So give us an overview from a global epidemiological point of view. What can you tell us about the size and scale of the long COVID problem?
Yeah, well, thank you. Look, there are many well-established epidemiological frameworks for working out how important something is. And these look at questions like the size and scale of a problem. So how common is it? How long does it last? How severe? How treatable? How good is our evidence? How certain are we of it? And how do we think these indicators may track in the future? And I think, unfortunately, long COVID is causing huge concern on all of these fronts. A very detailed evidence summary was just prepared and published last week by the Public Health Communications Centre as a briefing, and there's a link to that on the event website. And this was led by my colleague, Dr. Amanda Klausvig, and it included myself, Paula, and Janine as co-authors. But what this evidence summary shows is what I think many of us have become more and more aware of over time, that long COVID is not one condition, it's a collection of conditions. At the severe end, you have illness like circulatory diseases such as heart attacks and strokes, which can be fatal, and that's part of the spectrum of long COVID. It's certainly an established cause of ME and chronic fatigue syndrome, which we'll hear more about. It causes a very wide range of specific symptoms, particularly fatigue, and what is often called brain fog, but actually is cognitive damage to our brains. And these obviously have a huge impact on the quality of life and productivity of people. It also causes hidden effects. This is tissue damage and physiological changes that may not cause apparent symptoms at first, but may predispose to later disease. We just don't know yet. We have a large body now of well-designed studies that suggest the prevalence of long COVID is around in the range of 4 to 14% of people experiencing changes in their health status following COVID-19 infection. They may follow any variant or subvariant. They affect people of all ages. They can follow a first infection and reinfections. The duration, obviously, we don't know how long they'll last because this virus has only been with us for a bit over 4 years, but many people are experiencing long-term disability, and this may be permanent, particularly based on the experience of ME and CFS. We know it's unfortunately not curable at present and has limited treatment, so prevention is really critical. And what I would say is the evidence has firmed up over time. It's not just based on questionnaire and self-reported data, it's also based on testing, for example, brain scans that do identify physiological changes in the brain, in blood vessels, and other organs. There are also suggestions or concerns about its impact on the developing brains of children and adolescents, and also development of the fetus in utero. And one of the problems of COVID-19, as we all know, is that this virus itself, which causes long COVID, of course, is continuing to evolve. And that means the infection is always with us. and it's causing periodic waves of infection, particularly linked to new mutations of the virus, causing new waves of infection. So in summary, it is a very large problem for affected individuals, for societal functioning, and also our economy. And the evidence is overwhelming that we need a vigorous, evidence-informed response.
Brilliant. Thanks, Michael. That was a really, really nice, firm overview to get us started. Loads of things to bounce off there. Paula, I'm going to turn to you next. Would you be able to zoom in more on the New Zealand context a bit for us? So you've been doing a lot of research mapping patient experiences here in Aotearoa. What does your research tell us? What doesn't it tell us? And I'm particularly keen there to hear who's most affected, for example, what the condition looks like for people in terms of duration, severity, and so on. What can you tell us about patient experiences? Sorry, that was a lot of questions, but just tell us about your research.
Thanks very much, Carly. So as I alluded to in the introduction, Janine and I have created the Long COVID Registry, and this has been funded by the Ministry of Health. So it was established in July 2023. And the idea is to understand the burden or the impact of long COVID on those who are experiencing long COVID symptoms. So, what's the symptom profile? What is the impact on quality of life? What's the impact on people's employment, their ability to get benefits, impact on their whānau and the community, right? So kind of quite a broad and possibly at the time ambitious, now it's still very ambitious idea of trying to understand this huge impact. So REACH started in July 2023. It's still going. I should say we're due to write a report for the ministry at the end of this month, and so there will be a final report, but we won't close the registry because, as Michael just said, COVID infection is still happening, long COVID is still happening, so we will still keep recruiting into the registry so we can understand the experience of individuals. We did a data extract. We're doing one right now at the moment for the final report, but the most current one I can report on was at the end of January, and we had nearly 1,300 people registered. And so predominantly they are female, and this aligns with the international evidence that there are higher odds of developing long COVID as a female. And I'm sure Warren can speak to the science on that. They have an average age of 45 to 49, and so I like to think that that's the kind of most productive part of your life. You're often a carer at both ends, right? You've got children and you've got parents that you're caring for. So, this is at a point when you're, a lot of people are relying on you. A third of the participants were essential workers, and a number of them were health workers. And of course, we know that they were of greatest exposure because of their jobs. Nearly all are vaccinated, which is what you'd expect because this is New Zealand. We had mandates, and most were infected with the Omicron variant or the later variants. And it was actually because of that vaccination and the variant that I thought it was really important that in New Zealand, and the ministry obviously agreed this as well to fund us, that we actually created our own evidence because the experience of the pandemic in New Zealand was so different than it was elsewhere. And so what do we know about the individuals in our study? I was trying to think of one word that might kind of sum it up, and I'm sure most of the people that are on the webinar who've got experience of this, probably can't sum it up in one word, but I was thinking it's grim, it's stark, it's crushing, there's a lot of words like that. But one thing to point out is that these were healthy people before COVID, so we asked them in the registry, got them to recall what life was like. And we're not saying, they were all perfectly healthy. They weren't, but they were very similar to a study that's been done just on the general population, right? So they are Joe or Joanne Kiwi, right? Now that when they join the registry, now their quality of life is very similar to those individuals who've got cancer and MS. So that kind of just goes to show the kind of chronic burden of it. We've continued to track individuals monthly in terms of their quality of life. And for some, there's been some improvement. For others, they're still kind of flatlining at this quite low level of quality of life. We know people have had to reduce how much they're working, between 7 and 9 hours a week. We know that 30% plus have taken leave without pay. And we know that 70% of people are working despite being unwell. So, this is evidence of not just absenteeism, but something we call presenteeism. And it's no wonder, because when we look at symptoms, like 90% have had are reporting fatigue, which is not improved, sleep disturbances, loss of concentration, or what's often called brain fog, muscle and joint problems. These are all very common symptoms, and they kind of align with the international evidence. So actually I could speak forever, and we will be speaking forever, not that long in the final report we'll write. But I just wanted to say that, you know, for those who are interested, and we'll put the link in the chat, if you haven't yet joined the registry, please do join the registry, because this is one way that we are being able to aggregate the voice and the experience of individuals with that data. Yeah.
Thanks, Paula. That was great. And I'm sure we'll be able to get some more details out of you about your research as the webinar progresses too. So just looking at this through your lens as a professor of health economics, what can you tell me about some of the implications of this kind of burden of illness for the wider community?
So I think the implications are huge, and maybe that's because that's the way that Janine and I set out to study it, right? We didn't want to just look at the healthcare system. So there are I think there is a considerable burden on the health system, and there's unmet burden as well, which I suspect Janine will be able to speak to, and because it's not clear what specialist services are available. So we're probably having a lot of this burden fall on our under-equipped GPs in that kind of sense. There's obvious burden on the labour market, and this resonates with lots of the international evidence that kind of shows long-term absences and unemployment as a result of, you know, post-pandemic, which may be for other, you know, reasons of epiphany while you're during the pandemic. I want to give up working, but there's lots of people who have had to give up working because of their long COVID symptoms. Obviously, these people and their whānau need support. And so I think if we don't support individuals with this chronic condition, then we'll be pushing people into poverty, and that's just going to exacerbate their poor health, right? So we've got to kind of break that cycle before it starts. So I guess in terms of the implications for me, I think, and I'm sure we'll get to this, and we highlighted it in the review article last week, is we kind of need this all of government response. So yes, the Ministry of Health has funded this, and they, along with Te Whatu Ora, are in charge of developing guidelines and thinking about services delivering for long COVID, and also having a stance on COVID infection and reinfection. But I also think like WINS and MSD should be interested in understanding what is the long-term absences and the need for benefits to support people and support their carers. So carers support. And, you know, even places like MB should be interested, because there might be some need to review sick leave entitlement. And I really think the Treasury should be very much interested. And I could probably speak to later the fact that they had an unofficial report a couple of years ago, which they really should perhaps be updating, because I think the evidence is now much clearer that there will be a considerable impact on the economy.
Yeah, it stands to reason. It absolutely must be, mustn't there, with those kind of findings. Thank you. So, Janine, let's move to you now. You've been working with Paula on the panel, producing the research she's just talked about, and you are also a long-term patient and a patient advocate. Do the results you're seeing reflect your experiences living with long COVID and working with long COVID support Aotearoa? It'd be great if you could tell us a bit from your perspective what it's like for patients living with long COVID, and what are some of the biggest challenges they're having to deal with?
Yeah, sure, thank you. Absolutely, look, it's been a real pleasure being able to work across the universities, across the motu, and how wonderful to see them collaborate so nicely together. And it's been, you know, just extraordinary process from get-go, from, you know, March 2020 when I first was reached out to by Dr. Anna Brooks, and it's continued since then. Look, I think, you know, Paula's right. We went in with really ambitious expectations in what we'd be able to extract out of the registry, and I guess that hope that every person who has long COVID would be able to raise their hand, or at least in somehow be identified, and then we'd be able to show very quickly this huge volume of people, which clearly demonstrates the burden that it'll have on Aotearoa. But the reality is, one of the core things we learned, it was that vast majority of people do not know that they have long COVID. And I think this comes from a reality is that it is an umbrella term. We do not have biomarkers. And so we do not have that trickle down that happens when you have an identified biomarker, and then we're able to go through a process, and the Ministry of Health is able to identify it, and then it's sent out, and it's pathways created. There's frameworks, there's symptom mapping, there's so many things that would happen if this was a recognizable disease from that point of view. And so what that means is that it's a bit of a wild west out there in diagnosis. Whether you get diagnosed is going to be dependent on whether your GP at this stage believes in it. And unfortunately, there's a lot of mitigating circumstances that are surrounding that. Patients are walking into overworked GPs who don't have enough time, and certainly chronic conditions are a very challenging area for GPs to be able to address. If you've got 15 minutes to squeeze in something that's probably going to take you more like 2 hours to work through, and you need that on a regular basis, that's quite a burden for them as well. And so often what they'll do, of course, is work out from a symptoms point of view and prioritize those and work out what needs addressing first, which is a completely reasonable framework for where they're at right now, with the information that's been provided to them. And it's a really hard expectation for GPs to keep up with the data that's out there. And that's one of the reasons we've done the PHCC briefing as well, to ensure that there is a level of information provided. And there'll be more of that to come in the future from that point of view too. But it does mean that the patient experience could involve not even knowing that they have long COVID in the first place. So when you turn up and you've been sick for some time, but you don't know really what, a question may not be asked of, have you had a recent COVID infection? Because a lot of people have. It may not be very obvious. For me, it was some months later that I realized that I was very, very inflamed, and then had a surgery. And then after that, my world fell apart. And I wasn't able to do anything. Everything stopped working. Every part of my body stopped working. I couldn't walk, I couldn't eat, I couldn't exercise, I could barely talk, I couldn't sleep. It was just every single direction of my world fell down. And of course, nobody thought to pull it back to COVID. And I don't really think much has changed since then, to be honest, and that's nearly 4 years ago. If you're very lucky and you've got a GP that does understand that it's looking out for this and is trying to keep informed, the best you can really hope for at this stage is a little bit of moral support, to be honest. And that's a pretty disheartening position for a lot of patients. And I think then if you add to that, the other part of the experience, of course, is the societal reality of this. And we are sitting in a deep politicization of COVID. It's very divisive. Having managed the registry marketing to get people to participate in this, I can tell you we've blocked something like 8,500 people. I'd like to say that there are nice people in the world, but unfortunately there's a heck of a lot of hate out there as well. And long COVID sits right in the middle of that. And so there's a really deep stigma that goes with admitting out loud that you have long COVID. Typically people present very well. It's a very invisible disease. And it does make it incredibly challenging for someone to stand up and say, I think I have this, or have the support and the courage to be able to do so, let alone the medical kind of proof to back them up. So I feel like there's a lot of challenges that come with trying to do the work that we have been. And it's been a much more difficult process than we probably anticipated. And that's become very obvious in the research outcomes as well.
Yeah. Oh, thanks, Janine. That's good to hear, though, shocking and sad as well. And we've also got some people sharing their stories in the chat, which is very brave, and araha to you guys. So Warren, let's talk to you now. You're a professor of biochemistry, and you've spent many years, as you said, researching both ME, CFS and long COVID. We've had COVID with us worldwide for 4 years now. What do we know about the condition from a biomedical point of view? Are we clear what causes it, for example? Can we diagnose it with certainty? I think Janine said we can't. And if not, why not?
Okay. So a lot of questions in there. So the first important thing, I think, to realise that this affects all ages, including children. And one of the positive things about having only a single initiating virus, it meant that the World Health Organization could rapidly establish a clinical case definition for the disease, which I think is important. How they did that was to get patients say what their symptoms were and then distill out what the most abundant symptoms were. Inadvertently, what they were doing was selecting out from a mixture of people the most dominant, what we'd call clinical phenotype or subgroup. And that turned out to have symptoms, core symptoms, that were almost identical to those established for ME/CFS. In other words, it seemed like the dominant group were an ME/CFS-like fatigue syndrome group. This was a bit muddling for going forward with the research, but fortunately last year there was a detailed study of 1,800 patients trying to determine the various subgroups within the umbrella term of long COVID. And what they came up with was about half of the patients indeed have an ME/CFS-like fatigue syndrome. That's the dominant group. So as the WHO clinical definition suggested, there is about a quarter have a respiratory syndrome, and that's likely from organ damage as a result of the effects of certainly the first two variants, the Alpha and the Delta variant, which were quite severe on the lungs. And then maybe a fifth, a pain syndrome, which may be equivalent to what we know as fibromyalgia. And then a smaller one they called a neurosensory subgroup. Now, I would have included that in ME/CFS because ME/CFS people have lots of neurosensory effects as well. So the conclusions from that is the major clinical phenotype is indeed an ME/CFS type fatigue syndrome. We've actually gained quite a lot of understanding now about the pathophysiology of the condition, that susceptible people, instead of having just a transitory immune inflammatory response, have a chronic response. And we have nerve cells in our body which can sense those kinds of things. And what seems to happen then is that signal is sent to the brain, and the brain has a separate immune system, separate immune cells, the microglia. And so the brain's immune system is activated, similarly with immune and inflammatory responses. And an unfortunate part of that is that the brain starts regulating body physiology in a slightly defective way. And so we get all the neurological symptoms of the condition, but also we have things like heart rate, blood pressure, temperature, digestive issues and things like that aren't being regulated as they would normally do. We're now starting to get some insight into the susceptibility factors which might determine why 10% of the population, for example, come down with long COVID after COVID infection, where most people don't. Most people just have this transitory inflammatory immune response and then recover. And there's been a big breakthrough in the last year where a group, a company in Oxford, Precision Life, has put a new platform onto what was known as genome-wide association screening, where people looked at every base through the 3 billion bases of DNA to look for a genetic variation that might be linked to disease. This has been done for ME/CFS and there were no links found. But what they did was to put a combinatorial platform on with weeks of computing to look at whether clusters of small genetic variations, just natural variations that, you know, make the difference between each of us, to see whether those would be predictive. And they found that small clusters, about 15 small clusters of 3 to 5 variations, could account for 91% of the patients' samples out of the UK biobank they tested. So this is really exciting because it looks like then we might be able to develop a test for people that are susceptible to developing the disease. So if a patient and a person in a family comes down with a post-viral fatigue illness, then other members of the family could be tested and some medical care put around them if something like a SARS-PAN endemic or continuing SARS infections occurred. In terms of diagnosis, we don't have a specific molecular diagnostic test, and I wonder whether we'll ever have one that covers the whole group of patients, because it's such a complex pathophysiology and it's variable from patient to patient. In other words, patients have the core symptoms and they have a subgrouping of the 200 symptoms that have been reported, but not have all of them. And so it might require more. But however, the fact that we know for long COVID that it comes from a single virus, the condition emerges soon after infection. It has the classic now symptoms, core symptoms defined by the clinical case definition. We have maybe up to 100 million people around the world that have had this, so there's plenty of information out there. I think there's no reason for clinicians to hold back on the most likely diagnosis of long COVID from these kinds of facts in the absence of a molecular test. Certainly not to go to a default position that they might be suffering from a somatic symptom disorder, in other words, a psychological thing. Sadly, that's what's happening extensively in less well-developed countries now, where knowledge and information about the illness is very poor. This recent report came out of South America. And sadly, even with some patients in New Zealand, because I've been told by some patients that their doctors won't even say the name long COVID or ME/CFS. And, you know, we should be long past that now. Is a molecular diagnostic test coming, and will it be available universally? There was a good publication of a test based on Raman spectroscopy of metabolic profiles this year, and it could be that something like that, an instrument could be established in one diagnostic laboratory in a country as small as New Zealand, and that could become a test. What we're trying to do, and starting a project this year with Aniruddha Chatterjee in the Department of Pathology at Otago, is to see if we can harness a molecular signature in the DNA among the light switches or the expression switches for the genes, because there's a possibility that that analysis can be actually put onto a USB stick and plugged into a computer. And if we can get a molecular signature for a diagnostic test with this, then that would enable every chempath laboratory in the country to have it, and every clinician and patient to have access to it. And that's the really important thing if a test comes. I was at a conference in November and happened to be seated next to one of the original general practitioners from Incline Village, Nevada, where chronic fatigue syndrome, that name given to the American outbreaks, came from. When we talked about the possibility of using artificial intelligence, and you know, one thing which might be possible in the future is, even if clinicians in New Zealand aren't that knowledgeable, they could put the symptoms that a patient came along into an artificial intelligent platform, which had all of the international data in it, decoded, of course, and maybe instantly be able to get back a diagnosis, but also a suggestion of the best treatment options for those people that had those symptom characteristics. So that's something for the future. Can I just add, to finish this question, there's one or two unfortunate things happening already that we are long over long COVID, rather like COVID. For example, recently the Queensland Chief Health Officer said he thought the long COVID label should be dropped because the effects of long COVID are no more than just the effects of getting the flu every year. And there's been a bit of a kickback on that, and certainly disrespects those people with long COVID that are suffering at the moment, but it's indicative of some of the narrative that's coming. Also, the US government gave $1.15 billion for NIH's Recover project, which was aimed to determine a recovery strategy from long COVID. They've just been given another $500 million. and not very much has come out of that. So there's starting to be commentaries suggesting we should drop the research effort and just focus on patients. That's not a bad thing, but not dropping the research effort. Can I say that one very positive thing that's happened recently is the evolution of patient collectives forming non-profit organisations like Patient-Led Research Collaboration, PLRC, and they are actually, from a patient point of view, collecting data and suggesting studies which should be done towards scientists. And so I'll say a little bit more about that, but that's a very positive thing. So I'll leave it at there.
Yeah, thanks, Warren. That was a lot to unpack, and hopefully we'll be able to delve into some of that in a bit in the question time. Just, that's about diagnosis and causes and so on. What about treatments? Are there any treatments we know for sure can help from your experience? What other research going on in that space?
Okay, so the bottom line is there is no cure for either ME/CFS or long COVID at present. And what's more, what we are learning is that even for a management strategy, there's no one size that fits all for individual patients. We need a management strategy that's really tailored for each patient. And that's probably because individual patients get a certain group of the symptoms that we know can exist with these post-viral illnesses. And so there will be quite a lot of variation in the dysfunctional physiology from patient to patient. So the best option at the moment is for a management strategy, I think, to improve the quality of life. I think we can be optimistic and positive about that. Certainly not having patients go after a magic bullet cure, because that is very stressful. And what we do know, we have insight that the best therapeutic options are ones that calm the sympathetic nervous system response, that's the fight and flight response, and promote the parasympathetic nervous system response, the rest and digest. So, my opinion is that patients need to be in control of their decision-making. Treatments, if they can do it best in their own environment, and restful therapies like meditation and yoga, but also including some cognitive therapies. And one that I've been mentioning recently is dynamic neural retraining system developed by Annie Hopper for initially her own healing and published in the book Wired for Healing. There's now an online program that people can go into and do a daily routine. And patients have reported to me that this actually gives them incremental improvement. And when they look back what they were like 6 months before, 9, 12 months before, they can see that there's been a considerable improvement. So things like this might be helpful. We have nutraceuticals, which can be appropriate for some people because we know oxidative stress is a problem. We know that from neuroimaging studies that some people seem to have lowered levels of the natural antioxidant glutathione, and so nutraceuticals can compensate for that. And we do have some promising drugs. And so one of the non-profit organizations, Open Medicine Foundation, is promoting the first clinical trial for ME/CFS, and that's with 2 of the promising drugs. One is low-dose naltrexone that some patients get benefit from. That's an anti-neuroinflammatory, and mestinon is the other, which is an activator of the vagus nerve system, which gives this rest and digest response. So there's some optimism that looking at those individually in combination might actually move us to patients being able to get to a better state. There are also people with MS like Courtney Craig, who's a nutritionist that's developed special diet courses for post-viral illnesses. And so there's been a lot of focus around diet and the size of meals, particularly because digestive problems, irritable bowel syndrome is a common feature. And can I just add, perhaps to finish, is that in the absence of what we have now are not an effective coordinated national support services. New Zealand has fantastic non-profit support organisations that are playing a great role in supporting patients and health professionals in the management of their long COVID and ME CFS. For example, resources are being provided by ANZME's No ME video podcasts and news series for health professionals relevant to long COVID diagnosis and symptom management. ME Support New Zealand, based in Auckland, has developed an extensive series of long COVID tools for patients, and then direct support for patients to help them manage their conditions is being provided by CCIS, based in Tauranga, but covering much of the North Island below Auckland, ME Canterbury and ME Awareness in the Canterbury West Coast region, and for Otago and Southland, ME ISS, which is based in Dunedin.
Nice, thanks, Warren. That's a really great overview of that. Janine, I'm going to just ask you to follow up on what Warren has been talking about and ask if there's anything you want to add in terms of treatments and ongoing research for patients.
Yeah, thanks. And good summary there too, Warren, and certainly echoes a lot of the things that we've been hearing and seeing within our group as well. Just to clarify, within Long COVID Support Aotearoa, we look after currently about 2,500 patients. This is a rotating number. People come and go as they need. Sometimes support groups can be a bit much, but it certainly is a great place to come if you haven't come across us so far. Please do join. It's a safely moderated group as well, and we're very, very particular about running that amazing group of admins. Look, from speaking from a personal point of view, one of the things that I went through with long COVID, and it's an interesting one because I don't really say that I have long COVID anymore, because mine has become a variety of autoimmune conditions that I now have to live with. And so none of my specialists talk about long COVID with me. They talk about Hashimoto's, or they talk about polymyositis, or they talk about whatever else it is that's in front of them that we're dealing with. And I go through periods of feeling pretty good, and times where my world falls apart. And I call it health snakes and ladders. And I spend a lot of time climbing up my ladders and making sure that I've got myself in a really good headspace and feeling really good about things. And unfortunately, then there's something that normally kind of just whacks me, and I had to try and figure my way back through it again. I'm at week 5 right now, post-recovery of a surgery that is a direct result from COVID. So it really does have extraordinary long, far-reaching implications. So when I talk about this, what I like to ensure that I convey to people is that privilege is such an important part of this for when people like me talk, because I've had so much access, and that is the reason why I have stayed involved and made sure that I don't go away, because I can't unsee it. And ableism was a term that I got to know really, really well. So when we talk about some of the therapies and treatments that people can go and do, there is privilege that has to be attached to that, because the reality is they're not accessible for people. They are expensive. They are limiting, and there's a whole variety of reasons why everyday people will not be able to do those things. Vast majority of people with long COVID are struggling with even knowing that they have that, let alone thinking about therapies or treatments or access to potentially really expensive courses. Being able to hold down a job or be able to prove that they can get the benefit. There's a long list of things that are stopping people from just living a normal life. Vast majority of people that we come across are struggling, and that is why quality of life is the score that's coming up in the registry. That is why it is as bad as it is. They're not believed, they haven't got support. And if we want people to take a positive mind-body approach, we do need to look at what are the very basic necessities of life that are not being met. And if we do that, then we will be able to support people who may well be able to start to do some things that allow them to get unstuck too. But before that happens, it's just an unfair thing to expect people to be able to think their way out of this. So we're quite tight on that one within our group in terms of how we think about the things that we can do to support ourselves, because it does really create that rhetoric and emboldens those who believe in the concepts of brain retraining and the likes of, that pass on to the patient that believe that they should just try harder. And I'm very, very, very conscious of making sure that we make patients know that it's not because they're not trying hard enough. So please don't feel like that's ever the message that's being passed across. That said, I have a therapist. I'm very much a fan of making sure that I'm doing the things to unstick myself when I can, but I have to be able to tread that fine line. And there's a joke that goes around in the group quite often. You spend half the time convincing yourself that it's not real, and the other half trying to convince people that it is. It's a really fine line, and it's a very hard mind game as well. So I just really want to make sure that people are aware of that. And the last piece I've put on that is just, look, lots of different things work for lots of different people. And yes, lots of people do recover. I hear these stories all the time. And generally it's time and it's rest. And those are really difficult things for people to be able to get if they're just trying to hold down a job and pay their rent and keep the kids going to school and food on the table. It's pretty hard to get rest at the same time. So that's one of the challenges that goes with that. And so that's why we encourage people to get involved in support groups as well, so that you can kind of get a feel for what might work that's similar to you, and then understand what is the pathway that you could take that might support your recovery too.
Thanks, Janine. That was great. And I saw lots of people in the chat applauding those comments as well. Michael, over to you now. We've got about 5 minutes before we switch over to 2 questions from the audience. I see there's lots of good questions in there. So I'm really keen to hear from your angle, which is, of course, public health. That obviously addresses the interface between health issues and government policy and regulation and things like that. So the big question for you is really, are we as a country and as the government taking this condition seriously enough, given the devastating and potentially permanent impact on some people's lives that we've just been hearing about? Is there enough happening? If not, why not?
Yes, well, I think everyone on the panel and many New Zealanders will know the answer to this question. We're clearly not taking long COVID seriously enough, or COVID-19 itself. I mean, we all want to put them in the rearview mirror, of course. We want them to go away, but ignoring these problems will not make them magically disappear. And we can see some manifestations of this lack of interest. We don't have a very strong, clear strategy. At a societal level, at a government level, we're seeing a lack of strong messaging about the importance of these conditions and how to manage them, how to prevent yourself getting infected, where to seek help, the importance of vaccination, and also a lack of long-term surveillance of long COVID and associated research, just the basics that we need to track this problem. I mean, yesterday we saw a pretty vivid example of the fact that there is some disorganization at the government level. That was some confusion about whether the long COVID expert advisory group even existed, and the fact that it was formed in 2022 and it actually ceased functioning that year when it had done its job, but there still appeared to be some view that this group was still there advising the government. I could say that I'm not sure if we have any ongoing COVID-19 advisory groups left. I was on the COVID-19 Technical Advisory Group for more than 3 years, and that's now been disbanded. So I think that these are all evidence that we're not taking this problem seriously enough at this stage.
Right. Sad to hear. But can you also then take us through what you think we should be doing better? What should we be doing to prevent people getting COVID in the first place? And how do we also, I think, how do we ram home the importance of doing that? So as part of that question, I'm kind of wondering, what are some of the things that might make officials take an illness seriously or not take an illness seriously?
Yeah, and again, one of the reasons that we put out that evidence summary was because we felt that more action is certainly needed. This is the document that Amanda Klausvig led and is hopefully on your website. And there are 3 things we recommended should be done now. And one is to do a comprehensive risk assessment to say, what is the scale of this problem? How is it tracking going into the future? And how we should have a proportionate societal response. And that is really multi-sectoral. And so that is obviously something that should be done now, but it shouldn't hold us up from doing the other things we know are important. We do need to reduce infection, reinfection rates. That's what's driving this infection. We know every time you get this infection, no matter how many times you've had it before, there's a risk of getting long COVID. So these measures for turning down infection rates are basic public health and social measures that we've heard over and over again. We know these work: self-isolation, improving indoor air quality, using face masks on places like public transport where the ventilation is very poor. We just saw yesterday, the World Health Organization's put out new clean indoor air guidelines. There's a global movement in this area that unfortunately New Zealand is not following. And the good news is that these also reduce filling up our hospitals with respiratory infections and obviously mortality, as well as preventing long COVID. And of course, the last area where the evidence is very strong is that high vaccine coverage also protects people from long COVID. So these are all things we can do now. We don't, while we're waiting for a complete or a full risk assessment.
Nice, thank you, Michael. Right, so can I just throw it to the rest of you then to sort of follow up on what Michael's just said? In your view, are there things we should be focusing more on that we haven't yet talked about? It could be things in terms of public health interventions, patient support, treatment, funding, research, public education. I'm sure we want to do all of those things, but perhaps, the things that really stand out to you guys, what else could help? And also maybe what could keep the pressure on the government to make sure that happens?
Yeah, definitely a lot. Sorry, after you, Warren.
You want me to go first? Okay, yeah. Could I just, push my barrow of education for doctors in our medical schools, emerging doctors in our medical schools. So there's an effective program understanding these post-viral illnesses, understanding evidence-based best management practices, which are, a group of the US clinicians, expert clinicians, published in 2021 in a Mayo Clinic proceeding. So we have information so that there can be consistent support for patients across the country. So all patients, when they go, will have doctors who understand the illness to a certain degree and can express knowledge and empathy, and we just get a consistent, effectiveness for the patients that are, because we've heard already patients feeling they're not getting appropriate treatment.
Janine, did you have something to add there?
Yeah, so look, there is a lot going on in the background, and everyone should take a lot of heart from that. I know it can be incredibly disheartening to see the kind of rhetoric coming out yesterday of, saying that there's advisory groups and programs and all the rest of it. In reality, there isn't. And of course, that one step further of taking credit for it. Look, and for us around this table, we all work really closely together continuously. And as I said before, there's a lot of mahi in the background, and there's a lot of cross-university collaboration. I'm a big fan of innovation coming out of private sector and individuals. And this is not about commercialization. It's actually about where are the people who really want to see this change? And that is what was being said before about patient-led groups. We are the ones that hold the power, and whilst it might feel like it's a really hard burden to also take on board when you're not feeling that great in the first place, there are also a lot of us. And that growing group means that there's a lot of really smart people with a lot of networks and a lot of capability, and we can get organised, and we are organised. So I really want to make sure I lay down that hope for people who are listening here, that it might feel like we're behind, we are, and it might feel like there's not a lot being done, and that's true, but there is a lot happening in spite of that. And one of those things that, for instance, that Paul and I and Te Here and Waka are working on as well at Victoria University are looking at mapping out pathways and symptom mapping. There's so much data that already exists out there about this pathway and experience for customers. That's my customer experience coming in for patients. And then how do we take that information to be able to build a much more comprehensive approach for when you do turn up to your GP that makes it easier for them to go through diagnosis in spite of not having biomarkers. It makes it simpler for them to be able to support you when they have small amounts of time. And so that is underway at the moment. We really hope that we'll be able to get funding to continue that through to get a pilot up and running. And that gives me hope that something can come out of the other side of this. Realistically, what we've seen is that the most important thing that we can do is support someone through it. Because we don't know how long it might be or what might happen to their body or how the immune system might react. But we do know that quality of life can improve if someone is believed, they feel supported, and they're taken through the process, and they're not having to constantly be vigilant. When we talk about all these things about what you can do for yourself, nothing can faster counteract that than you having to constantly be on guard because you know people aren't believing you or listening to you or taking it seriously. And so we want to be able to create systems and processes that make it so much easier for a patient to be able to say, it's okay, I know that they see me, they've got me, and my information is going with this at the same time. So that's what I really wanted to put out there for everyone, is that is coming. We are working on that. And if you've got any skills to be able to help support us in doing that, we'd welcome you to get involved as well. Just please reach out.
Thanks, Janine. Really important points. Paula, did you have anything you wanted to add there before we go to questions from the audience?
No, I think let's go to questions from the audience.
Cool. Just remember, everyone, that you can vote up questions that have already been asked. There's been 57 questions asked, so for me to ask the ones that you're most interested in, I need to know what you're keen on hearing the answers to. So we're going to start first with a question. Oh, it looks like Amber's question at the top. Why is New Zealand so far behind in terms of allowing young people to access COVID vaccines? Is that one for you, Michael?
Yeah, I don't know. I mean, I think there was initial perception that vaccines were mainly to stop people getting seriously ill and dying, and they're very good at doing that. And we know those risks rise exponentially with age. So I think there's been a huge focus on high vaccine coverage for older people and people with underlying conditions. So I think that the vaccines are not being promoted for preventing long COVID and the huge benefits for younger people. So I think that's an area where the practice is not caught up with the evidence, and I think we can do much better. I think also we see different practices. The US and the UK have very different strategies for vaccination. The US is focused on vaccinating right down to young age. The UK has got a huge focus on people, maybe even focusing on 65 or even people 75 and over. So very different approaches in different parts of the world. I think we can do much better here.
Yeah, I've really noticed that the public health focus has been on stopping people getting into hospital or dying, which is obviously extremely important as well. But there hasn't been equal focus on risks for long COVID and trying to stop that. So good points. Thanks, Michael. Question from Lecture. Is there a risk in relation to getting your next booster if you still have long COVID symptoms? Is that you, Warren, perhaps?
Yeah, I mean, there's some mixed information about this, that whether you'll be more sensitive to adverse reactions from a vaccination if you're in the situation. We know, for example, with the MECFS community, they had high incidence of adverse reactions, 1 in 4 from a survey done by Enzimi. So they were a population that really had to be looked at very carefully, in the background of a very successful vaccination campaign, where at the start, of course, we never knew whether it would be possible to get a vaccine that would actually help in this pandemic. And the RNA vaccines, they're highly reactive, but the other thing, they can be adjusted very rapidly to a new variant. So that's been very successful. But, for these vulnerable populations, like people with MECFS or now long COVID, they have to be cautious, because the evidence is 1 in 4 can get their diseases made more serious from the vaccination.
Did you have anything to add to that, Janine? Or
yeah, look, it's such a challenging topic, as you know, and it certainly made our registry collection so much more difficult. I think in lieu of there being any education or any information being handed out by ministry about the role of long COVID and how a vaccine can help, that has meant that in the absence of that, disinformation has appeared quite largely, and a large percentage of people are of the view that long COVID is created by the vaccine. We hold a very clear viewpoint of that, which they are very separate things. The vaccine is I use this word lightly, but in terms of injuries or other recurring issues that come as a result of vaccine are separate to long COVID, and they are considered formally as a name of a post-vaccine issue. And when we put them together as the same word, it confounds the issue. It creates it more challenging for patients to be heard because it gets lumped into conspiracy buckets, and it just gets really hard and really messy really fast, and invites a whole heap of extremism. And that is the bit that gets ugly, and 8,500 people get blocked. So we try very hard to separate those two out and focus on long COVID as a result of virus, and hope that because that's our area of expertise, and hope that other groups can sort themselves out to support anyone who has on another side. Everybody has their own individual perceptions on it. Not a lot of people have a lot of data on it. And, I can speak from my own experience, which is that long COVID got better as a result of having the vaccine. But everybody will have an opinion, and that doesn't necessarily help us anyhow. That is an area that does need to be dissected and spent some time on, because it's terrifying what's happening. Child immunisation rates are going down as a result of less trust in vaccines. This needs to be addressed, but it needs to be addressed separately to the long COVID conversation.
But I think we have to be absolutely clear. The epidemiological evidence is unequivocal that the risks from COVID infection are far worse than any adverse effects from vaccine. There's no question about that from huge studies across the globe. We also have to be clear that the vaccine protects you from long COVID. In multiple studies now, it's possibly a 50% reduced risk. So that's also very clear. Now, for individuals who have a range of conditions, in particular cases, there may be a need for caution with vaccination, particularly if you've had an adverse event previously. That's probably a very specialized area, but that's likely to be a very small minority.
Nice, great answers, thanks. I'm just going to ask a question about, oh, where's it gone? They keep getting voted up and down, and I can't see them. A question by Jill about, this is probably for you, Paula, actually, what research is being done in Aotearoa to understand the economic impacts of long COVID now and into the future? She's particularly interested in the impacts on organisational resilience and planning, and how we manage these in a proactive way to support employee well-being.
Yeah, there's interesting parts of the economic impact that the registry is actually not going to look at. So the registry is looking at it from an individual perspective, and I guess their contributions to employment. But we did have, just to plug, another webinar that we did, I think, back in 2022, that everything's blurs together thanks to a pandemic, which was about work and long COVID from the University of Otago, where we actually had a couple of companies that had a very proactive approach to managing COVID, and I think therefore managing long COVID. I think acknowledging that it is a chronic condition, and you may need to give staff time off if they're unwell, and and feel that they're secure in their job, is going to help with having a good workplace that people want to work in. I think research in this area, yes, it's needed. The registry won't answer it, but it doesn't mean to say that it couldn't be answered, which should be, I would think, something that MB would be interested in.
Nice, thanks, Paula. Question from Melanie about thoughts on getting clean air into schools and kindergartens. We know that teachers are more susceptible, don't we, because of all the FaceTime that they have with children. So Melanie says, from her experience, there seems to be no interest in ensuring this happens. Some schools have 100 kids in the same room in the new open plan learning environments, not to mention assemblies. Is that one for you, Michael, perhaps?
Can I just jump in before Michael does, which
sure.
is, I'm deeply concerned by current government conversations that they're going to be looking not necessarily at truancy in schools, but actually sickness and absence. And they may be trying to encourage parents to send their kids back to school if they're unwell. Why would you send an infectious vector back into a classroom to infect other children and their teacher? So, I mean, that's just different parts of the government and not having that broader view of how important health is and the social determinants of health.
Yep, I think that's a very good point there about policy. I mean, you need a strong strategy, and with a very intentional focus on making the school environment safe for teachers and for students. And you're right, the modern learning environment of 100+ students indoors means that those students and the staff are highly exposed to this virus. And that was the evidence we had when there was a first analysis actually done by the Ministry of Health, showed that we thought healthcare workers were the most vulnerable. They're not. They have good infection control procedures. Actually, it was school teachers who had the highest rates of COVID infection. It doesn't do anyone any good to have infected children or staff turning up in any workplace. I don't know why any employer would even want that. The other thing is that the biology of this virus is that you're often infectious for up to 10 days. 7 days, most people have cleared the virus. 5 days, you've still got about 30% of people are still infectious. These are cutting corners already. So we do need a policy. I mean, the number one thing is you do not have infected people mixing with well people. That's the most basic infection control measure you can have at a societal level. One thing we've learned, hopefully, from COVID-19 is don't soldier on. You know, the old ads, they've disappeared. You don't see those anymore for very good reason. So we need a massive cultural shift into saying it's not normal to get multiple respiratory infections over and over again. There's not just long COVID, there's long influenza, of course, and almost every infectious disease has a long shadow. So we do need to be shifting our expectations at a societal level. We need government to take the leadership and say this is intolerable. And then we need a whole series of policies stacked up behind that about how we occupy all shared indoor environments. And New Zealand really is being left behind. I was attended a virtual meeting in Australia yesterday in Canberra, and this was really focusing a huge effort across Australia on shifting all their policies. WHO is taking leadership. We have to actually catch up with the rest of the world on this.
Thanks, Michael. Really strong and sensible words on that. Agree wholeheartedly. So question from Sarah next. How do we stop GPs suggesting dangerous treatments like the lightning process, which is damaging to people with ME long COVID? My daughter is now severe pushing through following a lightning process course, as suggested by well-meaning GPs, has now for 5 years been in bed with severe illness and cannot walk and so on. Sounds absolutely horrible, Sarah. Who wants to answer that? Is that you, Janine? Or, yep.
If you don't mind. I'm really sorry to hear that, Sarah, and that's a really awful example of what unfortunately we do hear a lot back from patients. And the problem with there not being any peer-reviewed scientific studies that back up a lot of these brain retraining lightning process type of things is that there are these people who are heading back just broken as a result. And so while some people are getting some great outcomes, there's no tracking of that for the long term, and we don't know whether they've actually end up seeing it over that period of time come back out the other side. And I'm really conscious of when I say that in itself is quite a political football, and it has become one between all of us. You know, everyone on this call will be well aware of the conversations that get had between us and various organisations that are pushing for it. And we sit on completely different sides of the spectrum of here, and it appears to be everybody's quite rigid. And what I offer is that every person I know who has long COVID fundamentally, absolutely wants to get well, and they want their life back, and they will do anything to get there. And they will try anything, and if they have the money, they'll fork out for it because they'll give it a crack if they think that will mean that they get their life back. But it's so important that what it is that they're trying doesn't also create harm for them. And that is the really big issue that comes with when things that are not tested over the long term or take a scientific approach are being recommended through our GP networks. My GP that I had before my current one, who I fired as a result of telling me that I should do the lightning process, her reason for putting it to me was because she didn't know what else to say. She was feeling so sick of not giving the answers that she felt some answer was better than no answer. And that's pretty challenging, right? Because I think I prefer no answer than one that tells me that I'm not allowed to ever talk about my symptoms ever again to anybody, which really comes back to this idea of I have to think my way out of it. And that's incredibly harmful and dangerous. I do believe in mind-body connection. I do believe that there are lots of things we can do, but I do not believe that this is the way that we fix everybody at all. Undoing why GPs are being sent this is deeply flawed, and that is because they are time poor people. They are sent stuff all the time, all day. They do not have enough hours in the day, and so they are probably gleaning over, skim reading information that's sent to them. And there are a couple of trusted platforms that are sending them this at the moment, and that is dangerous. And we have put in formal complaints with the funders of these platforms to ensure that they are hearing from patient groups that this is dangerous as well. So I can assure you that we're hearing it and we're doing everything we can. And I hope that we can keep supporting, and we can also offer some ways in which we can bring this sort of patient support forward and other research too. So I'm really sorry that you are going through that. You are not alone.
Thanks, Janine. Time's moving on. We've got probably time for two very, very quick questions. This next question actually is also for you, Janine. What is the best way to connect with you if we want to get involved and offer our skills within our energy envelopes?
Yes, please. And look, I'm just clarifying that I am not looking for patients to come out and do anything, because you shouldn't do anything other than focusing on yourselves. But on this call are a lot of people with influence and opportunities to get involved, and I encourage you to do so. And that includes ministry people, etc. Everybody on this call here is willing to and is continuously offering up hours and hours and hours and hours and hours of help. This is what we are doing, so please do get in touch. longcovidsupport.co.nz, through Facebook, Long COVID Support Aotearoa. You can find me on LinkedIn, and the same goes for the vast majority of these people we can connect you with as well.
You can also email Helen Clark Foundation if you want to get in touch with anyone, and I can forward your email on. So last question, I think. There's just so many good questions here. I feel very bad about cutting them short, but we do have a time limit for our webinar, unfortunately. So Anna is asking if any work's been done on wearable trackers in New Zealand for heart rate and so on. The Visible app is an example, but that might not be made available in New Zealand unless enough interest is expressed. Yeah, any comments on wearable trackers, Paula or Janine?
So one thing I didn't say about the registry, two things I want to say actually. One is that you just need to self-report symptoms. So you don't need a diagnosis to come in, because we acknowledge that it's difficult to get a diagnosis. So if you self-report symptoms, which are well described on the website and on the ministry website, Te Whatu Ora website, then you can join the registry. When you join the registry, we ask you to consent to follow up further surveys, and also to take part in other research. So, the idea is that we would promote the registry and the population of the registry to other studies, one of which is a conversation which has branched into a conversation I've had with a colleague in exercise science here at the university, who's going to, hoping to see if she can get enough trackers to do a kind of study to understand actually what is happening in that space. And so another, and it's not, research is not, as I think many people have said it in the discussion, the chat, research is not a substitute for a treatment, but in fact research can tell you a lot of things that you won't get in the absence of a system that doesn't have any treatment, if that makes sense. So that's one reason why we thought it would be a great idea to have a cohort model where you can then take part in research. So the answer is, I don't know of any research at the moment, but it is on the horizon because someone has been interested in that.
Yeah,
Nice,
and it's
thanks,
come through to me as well, and we're certainly looking at the role of that within the chronic condition pathways research that we're undertaking, and that conversation has come up with the GPs that we're employing on it as well. So it is certainly in conversation. It's not.
Any final words from you, Warren or Michael, before we bring the webinar to a close?
Yeah, I'd just like to say that, some really interesting things that I'm hearing about that I didn't know was going on. And so we need to get these kind of things above the radar so everybody in our society understands this, rather than, and particularly for patients that are, I think, a bit isolated and not necessarily connected in, because when we were first an ME/CFS family 35 years ago, there was no social media or groups that were sort of supportive. So one felt absolutely isolated and alone. And I think it's really important to get this information above the radar so people don't feel quite so isolated with their conditions.
Michael, any final words?
We just really want to thank Janine and the patient community for really motivating all of us to spend time working in this area. And also thank very much the Helen Clark Foundation for organising this webinar. I think it's very timely. So, and thanks for the participants as well for their great questions.
Nice. Well, sorry guys, we're going to have to round it off. Thank you so much for watching. That was, I think, an action-packed webinar. I'm going to be watching it back again myself just to take notes on all the amazing information that has come out today. It was far too much for me to absorb all in one sitting. Remember, our webinar will be available online on our website probably by first thing tomorrow. So if you want to watch back, you can do so there. Please also feel free to share with others. I really hope the session's been affirming to you, long COVID patients who've been sharing your stories. Thank you so much for being here. You're important, you're visible, you're not alone, even though it might feel like it a lot of the time. So please have hope and faith that things will get better. Also to any policy officials in the audience, I really hope we've convinced you, if you needed convincing, that any efforts you put into this space are not just hugely important, but also really, really urgent. I hope you'll go back to your desks with renewed commitment and gusto to stand up for patients and try your best to put some of those recommendations through that we've talked about today. Yeah, just a reminder that if you've enjoyed this, you can sign up to become a member of the Helen Clark Foundation on our website, and we've actually got a special on at the moment. It's our 5-year anniversary, so I've got a special deal. You get a free book if you sign up to become a member, so think about that. And yeah, let's end as we started. This is a karakia that acknowledges that our conversation and time together is finished for now, but it asks that the strength and life force of our ancestors be with each and every one of us. Kia taunga manakitanga, a te mea ngaro, ki ronga, ki tēnā o tātou, kia mahia te hua mākihikihi, kia toi te kupu, toi te mana, toi te aroha, toi te reo Māori, kia tuturu, kia whakamawa, kia tīna hui e, tā iki e. Thanks everyone.